Welcome everybody to this new episode of the dental podcast, a tribute to my father, Dr. Pablo Echarri. And today I have the honor to welcome Dr. Livia Minch. She's a private orthodontist in Wrocław, in Poland. She's also secretary of the Polish Orthodontic Society and instructor of the Tweed course in the Tweed Foundation in Tucson. It's a really pleasure to have you here, Livia. We have a very strong relationship since many years ago. I want to thank you to be here, and also want to thank you to invite us many years ago to the meeting in Polish Orthodontic Society in Wrocław, twice, I think, and also we had a very good experience in Tucson when you were my teacher there.
We exchanged
in the Tweed Foundation. So once again, thank you very much to be here, and of course I wanted to have you in this project because of the relationship you had with my father, and of course, apart from that, for the experience that you have in orthodontics, and I think that you can take to the young orthodontist and also to the experienced orthodontist just a clinical pill about your experience in orthodontics.
Thank you very much. It's my great honor and great pleasure to be here. Of course, it is also a sad moment because Pablo is not with us anymore, but I'm truly honored to be a part of this project.
Thank you very much, Livia. So I know that you have like your scheme about how to manage this conversation. It's not a lecture, it's more like a conversation. But the first thing that I want to talk with you is about the experience that we shared in Tucson. First of all, I don't know if you want to mention how do you know my father. I assume that it was many years ago, and based on that, a little bit or a briefing about your relationship with him or with the Tucson Tweed Foundation. I don't know.
Yes, actually, can I share my screen?
Yes, for sure.
That's great. Okay, just a second. I would like to share with you a few memories and few words because I was trying to think about it, and I think it was like at least 12 years ago. Yes. I had the opportunity to meet Pablo in Wrocław. He did a course for the Polish Orthodontic Society and for the Wrocław University, and it was a hands-on course about TMJ, which was a great experience. And that was the moment when I truly fell in love with Pablo. And I do hope that in this moment our friendship started. I had the opportunity to invite him to give us a course about TMJ and about the sleep apnea in Wrocław. And you were also the part of this project. You were also speaking during these courses. It was a great time seeing you both on the stage. And as you can see here on the pictures, well, maybe I will come back for a second.
Yes.
You were always able to gather a lot of people, and younger and more experienced orthodontists, and you had real groupies and many people who followed you. And well, we knew that when we will invite Pablo, it will always be a success. And we really appreciated his experience, his knowledge, but also the amazing way of sharing his knowledge and amazing way of getting in touch with people. He really knew how to explain the problem, and even the difficult problems started to be easy. So yes, that was a great experience. And then I had this unique opportunity to visit Barcelona, and I also gave a course about interdisciplinary treatment, which is my favorite topic. And I still have in mind this amazing moments, great restaurants, great dinners. and really fun lectures in your beautiful office, in your beautiful practice.
Thank you.
And finally, you decided to visit Tucson, Arizona, which is the oldest orthodontic school in the world. And every orthodontist should make like a pilgrim there.
Yes.
So this is an old good school teaching old good fundamentals. No matter what kind of biomechanics, what kind of philosophy do you use, you have to know the basics. And this is the course where the basics are taught and where you can meet many giants in orthodontics, not only the teachers, but also the students, as you can see here. So this is an amazing picture of you guys in front of the Charles Tweed International Foundation. And I even took some pictures. I placed it here, which I had the opportunity to take. I was so impressed that both of you, and especially Pablo, didn't miss even a single minute of the course. He was always the first one, leaving the last one, listening to very young instructors, as you can see here on the pictures, and super experienced and famous instructors like, for example, Jim Vaden.
Yeah.
So that was really impressive, and that was really something very, very important. And well, here Nathan Hammond, one of the course instructor and coordinator, was talking about the dimension of the dentition. But what was so interesting for me, take a look. Pablo was always in the first row. You with him, of course, but always in the first row, focusing, making notes, and asking questions. That was something amazing, and I think that that should be the best lesson for us. That no matter how experienced, how good, how famous you are, there is always something that you can learn. There is always something new. And even if you don't gain too much new knowledge, you can make new friendships, new connections, new relations. And also, you can always learn something, or at least make sure that the way you are treating is really good. So yes, that was a great experience, and I still keep it in mind. And I also put the picture here with all the giants, with Dr. Herbert Klontz, who is unfortunately not with us anymore, with Dr. Jim Vaden, who runs the foundation now, and of course you guys and Pablo, smiling and happy and in a very, very good mood, I think. I love this picture.
Again, this course was also really fantastic for me, because, and not only fantastic, because also it was a thing for me to understand and to realize that, yeah, as you've said, that no matter how experience you have, even for me to see my father with, I don't know, more than 40 years of experience, uh, that he was still with this, like, he was hungry of more knowledge, even if about the last of this almost 40 years of experience is like, of course, if he wants to do it, I have to do it also with him, because this is how it's supposed to be. Yeah.
Mm-hmm. I think that it was a great experience, but
Yeah.
also for me, it was amazing watching you both guys supporting each other so much, because this is a difficult course. This is a
Yes.
course about where you really have to work hard and
Yeah.
bend the wires and measure and count and think. So it's not the course where you can scroll the
Yes.
Facebook or Instagram,
Yeah.
and where you can really relax. It is a fun course. It is a good course with nice people, but a hard one. And I was watching you how much you supported each other, both. So that was amazing. And I am a mother. My kids are teenagers. And I was thinking, oh my gosh, I would love to have such an amazing relation with my kids in the future.
Thank you
So,
very much, Livia.
congratulations. It's
Thank you
something
very much.
unusual, not typical, and amazing, really amazing.
Thank you very much, Livia.
So that was the time in Tucson. And what I also can mention about Tucson is that we really teach their fundamentals. So no matter what kind of philosophy, what kind of appliance do you want to use? Is it going to be a prescription brackets or edgewise or lingual or, I don't know, aligners? You always have to make a good diagnosis and a good treatment plan. And without it, you cannot go further.
It will be a disaster. Yeah.
Yes.
Oh,
So
and,
this is,
and there is another thing which is that it's true that it has to it has to be it has to have a value to have or to attend a course that it's known worldwide. Every single orthodontist knows. I don't know if every single orthodontist will was attending that course, but it's true that every single orthodontist knows about that course. So I totally agree with you that, of course, there is some mechanics that I am not using in my daily practice, but there is some of them, some bendings and some mechanics that I am still using now. So yeah, from my point of view, it's one course that it should be mandatory to attend. Yeah.
Yeah, I agree. Thank you for this.
No,
Thank you for this sentence. But yes, I totally agree with you. Well, I know from your students that you are using omega loops.
Yeah.
So the Queen Omega. Yes, so you always can learn something on the course. But what I think has the greatest value is the awareness about diagnostics and treatment planning. Because later on, you can do whatever you want, and you can use many types of appliances and wires and intelligent solution, smart solution, etc. But without proper diagnostics and treatment planning, without the good roadmap, you are lost. So I think that this is the greatest value of the course. And well, I was really happy to meet you there, to be there with you, and to share this experience with you.
No, it was a really fantastic experience, Livia. As I told you, it was really fantastic. Also, I think that you've prepared some like slides to share with us the regarding the clinical cases about the limitations of the orthodontics based on the periodontal health, right?
Yeah, that's my topic. That's what I like the most. And if you agree, I would like to share with you a few slides and two cases.
Of course.
So limits, borders, restrictions. Usually these words carry unpleasant connotations, especially for the younger generation. However, they also help us stay on track. And especially in our profession, where certain limits should not be crossed. And we have anterior limits, posterior limits, vertical limits, lateral limits, and all of these limits can be anatomical, functional, and aesthetical. But today I would like to focus on anatomical limits. I would like to focus on the labial bone, referred to as hard tissue phenotype. And we can evaluate the hard tissue phenotype during the flap surgery, which is obviously not that easy for us orthodontists, and during on the CBCT. According to the literature, the hard tissue phenotype with the width of less than 1 millimeter is recognized as thin. Anything more than 1 millimeter is recognized as thick. However, hard tissue phenotype of 2 millimeter or more is quite safe, both for surgery and orthodontic tooth movement. Unfortunately, only 2% of our population has such a thick buccal bone. And the reality and all day, everyday practice is quite cruel because, according to the systematic review published recently, in more than 74% in the maxillary frontal area and in more than 60% in the mandibular frontal region, the buccal bone shows the width of less than 1 millimeter. Looks like we do not have too much room to move the teeth. Well, so can the facial bone width be increased through orthodontics? Simply saying, can we grow the bone? What's the literature saying? The animal studies performed by Zachrison have demonstrated that orthodontic expansion leads to the marginal bone loss. And unfortunately, human studies confirmed these results. So that was one of the reasons why me and my postgraduate student, Dr. Alexandra Adamek, decided to do the research, and we compared the size and shape of orthodontic preformed night-eye arch wires available on the market with the initial size and shape and forms of the mandibular and maxillary arches of periodontally compromised patients. The results were consistent with other studies and showing that almost all orthodontic preformed night-eye arch wires interfere with the initial shape and size of patients' arches. What is interesting, the difference, for example, for the lower arch at the canine area can reach even 6 millimeters per side.
Oh.
That's quite a lot, especially when we are talking about periodontally compromised patients. So perhaps the hard tissue behaves differently when we treat our patients with aligners. So recent study published in AJODO have demonstrated that with the utilization of the CBCT scans, they showed that non-extraction clear aligner therapy is associated with increased alveolar bone dehiscences and fenestrations in adults with mild to moderate growthings. Looks like there is no hope for us. So why don't we ask ourselves the question, is the arch form, the size, and is the intercanine width really that important? And according to the literature, yes. All the studies published from 1936 till today, 2025, emphasize always the same conclusion. The intercanine width and the arch form is crucial, both for stability and periodontal health. So such a situation, which is unfortunately not that uncommon, is quite unfair to the patient. Eventually, majority of our patients finish orthodontic treatment with good occlusion and fair periodontal status. Why is that? I would like to quote one of the giants we talk about giants today, one of the giants in periodontology, Giovanni Tucchelli. As long as the patient has a healthy attachment, the gingival recession won't develop. And that sentence is confirmed by another giant in periodontology, Anton Sculeman, who claims that periodontal ligament is the king. I would say the queen, but anyway, periodontal ligament rules. Unfortunately, time works against us, and times usually is cruel, more for some so than others.
Yeah.
So when treating adults, especially those with periodontally compromised conditions, there is no room for inaccuracy, let alone mistakes. Okay, so why don't we start with some cases? A 54-year-old woman named Agnieszka came to our office seeking for help. She has noticed that her teeth have changed their position. And according to the literature, 20 to almost 60% of periodontally compromised patients suffer from pathological tooth migration. And this is what happened in this case. The CBCT reveals severe vertical bone loss. But what is even more interesting, she has also huge bone defects on the palatal aspect of central incisors. Those defects are extremely difficult to regenerate. So, what are the limits in treatment of such case? Even implantologists who are famous from doing everything to save patients' natural teeth, like Markus Hurzeler and Otto Zur, they know that there are some limits, and they say that with more than 80% of attachment loss, the tooth is hopeless. And undoubtedly, this is the case of patient's central incisor. So what are the alternatives? The first thing that comes to mind is obviously extraction, bone graft, dental implants, soft tissue augmentation, and crowns. That's a lot. The final result may be beautiful, but may be also disastrous.
Yeah.
And complication may be uncovered at any stage of the treatment. Additionally, periodontally compromised patients are more likely for peri-implantitis, so long-term stability is also questionable. Perhaps this is a good time to ask about the patient's expectations. So, does the patient agree to so many surgical procedures? Patients are afraid of surgical procedures. Can the patient afford such treatment? This is a very expensive treatment. Can we ensure a stable aesthetic effect? And last but not least, does the patient agree to extraction of otherwise healthy teeth? In her opinion, the teeth are healthy. There is no crown, no caries. She's 54, she's getting older and she doesn't like it. And she's ready to do everything to save her natural teeth. So what does the literature say about it? My research utilizing the finite element method have proven that floored incisors intrusion can be beneficial for bone regeneration. Animal studies performed by Bertha Melson have shown that orthodontic intrusion is good for bone regeneration. What is more, the intrusion can improve the quality of the new attachment, but under one crucial condition: perfect hygiene, ideal biofilm control. And the human studies confirmed these results. That is why we decided to try to save these teeth. Due to the severe bone defects on the palatal side, we started with surgery. The surgery was performed by Dr. Michael Hrobak, who also had this privilege to meet you both guys and who liked Pablo a lot. So he did the guide tissue regeneration, and as soon as the healing of soft tissue was completed, I started orthodontic treatment. And about orthodontics, it is super easy to align the teeth in periodontally compromised patients because there is almost no resistance. But it is also so super easy to extract almost all teeth during debonding. If we start with the labial appliance, the easiest and the first achieved movement is extrusion and proclination, moving the teeth towards the already very weak facial bone, because periodontally compromised patients have usually very thin facial bone. So to stay on a safe side, I start with the lingual approach, and I move the teeth upwards and backward, so towards the bone. And as soon as the healing and as soon as the intrusion is completed, I bond the labial brackets and continue orthodontic therapy. What is also important, all the wires are bent individually and coordinated to apply individual forces and to avoid expansion. And that's the final result. And the comparison before and after. But what is even more important is the CBCT. So the bone situation looks quite good now. And on the palatal aspect, we can see an amazing bone regeneration. And you have to believe me that the teeth are now super stable. And look at the bone regeneration on the palatal aspect.
Fantastic.
Before and after. That looks good. Thank you. Unfortunately, there are always two sides to the same coin. As a consequence of such severe retraction and intrusion, I also managed to achieve apical root resorption, which is probably clinically unimportant, but it exists, and we have to remember about it. Obviously, I'm not the only one, as the literature says the same. Orthodontic intrusion is the riskiest movement in terms of apical root resorption, and additionally, periodontally compromised patients are really likely to have apical root resorption. There is also the quite new study published 3 years, not even 3 years ago in AJODO, saying that the greatest responsibility lies on the pulp side defense mechanism. And this hypothesis reduces the force level importance in developing apical root resorption. So according to the authors, there is no way to predict or prevent it. It does not make me feel much better, but it explains a lot, because very often we have no idea why this patient have apical root resorption. And that's the final smile, before and after. That's the good improvement. So let's talk about other treatment alternatives in such clinically hopeless cases. So what are the current options? Option number 1, extraction of anterior teeth and implant placement. Not bad. But even with the best surgical procedures and ideal healing, the aesthetic outcome will always be poor. So option number 2, extraction of anterior teeth, bone and soft tissue augmentation, and implant placement. Again, let me quote the implantologist: aesthetics acceptable if you are lucky. And option number 3, the very modern option nowadays, extraction of all teeth and all on 3, all on 4, all on X, all on whatever. According to implantologist and periodontologist, aesthetics acceptable if you are super skilled. Summarizing, implantation in the aesthetic zone is always super difficult. Moreover, just 20 years ago, the success in implantation was rated only by survival rate. In 2004, Boozer and co-authors have emphasized that success in implantation zone should be re-established and focused on harmoniously scalloped soft tissue lines and contours. So our expectations are much bigger than it was 20 years ago. But 20 years, it's really not much. So we do not have too much experience. What is more, the complexity arises in periodontally compromised patients. So long-term stability is always questionable. Talking about long-term stability, I would like to present you one more case. That is my most hazardous case, but that was the first case that I treated with such biomechanics. There is no doubt that the incisors are hopeless. The central incisor is in so-called labial gap. And in this case, we have nothing to lose. So why don't we give her some chance and try to save this teeth? I started treatment with the same biomechanics, with the lingual approach, and I started intrusion and retraction. And then I bonded the labial fixed appliance and continue orthodontic therapy. And that's the final outcome. Not bad. But what about stability? I started in 2005, finished 1 year later, and I had the opportunity to see her regularly. So there she is in 2022. Now I treat her grandchildren, so we are still in touch. And there she is 20 years post-treatment, still with her own stable teeth. So the question arises, is the surgeon able to ensure such stable aesthetic result in the aesthetic zone in implantation in patients with a compromised periodontal condition? I don't know. This is the question for implantologist. Yes. Summarizing, the success in treatment of periodontally compromised patients relies on proper diagnosis, treatment planning, biomechanics, perfect interdisciplinary management, but first and foremost, total patient's cooperation and perfect biofilm control. So if we ask ourselves the question, where are the limits in treatment of periodontally compromised patients? Is the sky a limit? Not really. We have to keep the teeth in the bone and move the teeth towards the bone with ideal biofilm control. That's all what I prepared for you today.
Oh,
Thank you very much.
Thank you. Thank you very much, Livia. This presentation is amazing. Even if it takes 20 minutes, I know that here you have like 20 years of knowledge in 20 minutes. and
I hope
that's
so.
true. Thank you very much for
Thank you
that.
very much.
And I want to take the advantage to ask you two things. The first thing is, I know that you have in your own clinic all the team. So nowadays, are you using the CBCT to control or to measure the amount of bone that you have, or you still use the proof or not?
Oh,
Nowadays, it's enough to have the CBCT.
well, it's a great question. The periodontal probe is something like must-have for me. So when the adult patient appears in my office for the consultation, this is the first thing that my assistant gives to me. So this is something very important. But measuring is also very difficult because it is not so easy to evaluate the real proper depth. Even periodontologists have sometimes some doubts, not even mentioning about me, orthodontist.
Yeah.
And also, especially in adults who have some bone loss, who have some fillings and crowns, then sometimes the biological width is moved due to some treatment in the past, not really good treatment. So unfortunately, this is not easy, but this is the first thing that we do. And obviously, we also do the CBCT. I mean, every adult patient, especially periodontally compromised, has CBCT. This is always the question about, is the OPG enough or should we do the CBCT? But when I treat an adult, they usually have some periodontal problems. They have some endodontic treatment. They have some fillings, many, many different things. So to evaluate it really right, we take the CBCT because we have to remember that CBCT does not show all the bone.
Yeah.
And there are more and more studies showing us that this is not that perfect. I had the opportunity to present it in Barcelona.
Yeah.
So we have many cases where there was no bone on the CBCT. And when Michael,
And
our
you
surgeon,
open.
did the flap,
Yeah.
we saw not only a bone, but a really good quality of the bone.
Yeah.
So, we have to have it. We have to have the CBCT, but this shows us only the direction. But we cannot be sure that if we measured 1.1 millimeter, we have 1.5 millimeter. Absolutely not.
So this answer links also with my next question and the last one, which is nowadays it's like the main question, brackets versus aligners. It's the main question. But so, and time by time, you see on the meetings and on the congresses that everybody now is using the CBCT integrated with the software for aligner planning. So first of all, do you think that there is any differences in limitations of movement in that periodontal patients? It is true, and I know that you will be sincere because you don't have no problems to say the truth about it. It is safer the use of aligners in that kind of expansion treatment. And the other question is related with that. Does it gives us any value to attach the CBCT in that planning? It is true what the software show us?
Well, thank you for that question. I don't know whether we have 2 hours now, but I will try to make it quick. So, always when we improve the diagnostic, it is good. And it is very good to remember that we have a bone and that we have a bone limits. Because many years ago, if we took the impressions and we did the setup, what we did sometimes, we cut the bone, we cut the plaster, and we were trying to place the teeth in the right position. We had the alveolar bone, we had the plaster, and we knew exactly where are the limits. Since we started to take the scans, there are no limits. We can move the teeth wherever we want. So many treatment plans were magical treatment plans, okay? So and there were two solutions. One was we moved the teeth really outside the bone. And the second was that it didn't work. We wanted to align the teeth, but it was impossible because there was no room. If you want to move something, you have to have a room. I have my cup of tea here, and if I want to move it to the left, I have to have room.
Yeah.
And this is the same with the teeth. So if we take the CBCT and incorporate it to the treatment planning, this is great. Yeah, because it gives us the certain limits, borders. The question arises whether we really respect these borders. If yes, that's great. If not, then this is only the marketing value, and this is not, it gives us nothing. So this is the first thing. And the second thing is whether some technique is better or some technique is worse. Teeth are not intelligent, as far as I know, and they don't care.
Yeah.
Soft tissue, bone, teeth, they don't care what kind of appliance we used and how much the patient paid for it. So
Really,
they will
that's a good
move.
one. That's a good one.
I mean, they will move in that direction where we want them to go, and how much of force and how much of movement will we apply. So you can make fantastic things with the edgewise appliance and stainless steel straight wire, and you can probably make fantastic things with aligners. There are still some limitations of the aligners published in the literature, and we know that if you want to derotate the truly rotated lower canine, you really don't want to do it with aligners.
Yeah.
Or if you want to really torque the teeth, or if you want to align the curve of spine, this is really difficult. So there are some movements which are difficult in treatment with aligners. But you can do many things with aligners, and probably you can do it right. If we talk about extremely difficult periodontal cases, which I showed here, I prefer brackets and wire, stainless steel wire, individually bent, because it works like a splint.
Yeah.
And if the patient has an aligner and he put it away and put it back and put it away and put it back, then the teeth tends more to move, and they are not going to be that stable. Additionally, my issue and problem is with hygiene.
Yeah.
I know that theoretically, if you remove the splint and the brush, it can be beautiful. But our patients very often don't brush really well, but they want to cooperate. So they put the splint in, and then the disaster starts.
Yes.
So this is the second thing. And the other thing, which is my personal opinion, is the ecology.
That's
And the
very good
amount
point.
of
Yes.
plastic which we produce. And we, on one hand, we buy the glass bottles and we go to the coffee with our own bottles. And on the other hand, we change the aligner every 2 weeks. So for short treatment, probably quite nice. But if you plan long treatment to achieve good cooperation for the long treatment for the very complicated cases, I think that cheaper, easier it is with brackets. But this is my opinion. What I want to also say that is said that the development in orthodontics did not bring us improvement in the quality of the cases. So when I go for the conference, I see many beautiful cases and amazing treatment. But unfortunately, sometimes I also see treatment which is not good and advertised as a good one.
Yeah.
And excuses like we don't torque the incisor because we are afraid of root resorption, or something like that. And if you look at the cases published in journals 40 years ago, they were better.
Yeah.
So
No, even the one that are the plaster models that are in Tucson,
yes,
those cases are amazing,
exactly.
amazing. And it was about 1940 something, I think.
Exactly.
Yeah.
That was almost 100 years ago, 80 years ago. And they
Yeah.
were able to treat amazing. Obviously, they also had poor cases. Everybody has such.
Yeah.
I have a special drawer, which I want to forget about.
Yes.
Everybody has poor cases. But the thing is that where is the balance? I want to have small amount of poor cases and a bigger amount of better cases. And I think that this is at what we teach our students, because we have to accept that sometimes we have to accept the compromise, but also the level of the compromise is very important. So answering to your question, teeth don't care. We have to know what we want to do and where we want to move the teeth.
Thank you very much, Livia. Once again, thank you very much to join us in this project. Thank you very much to take your time to prepare these amazing slides. And once again, it's a really pleasure to know you personally. I know that it's hard to know how to find a professional with that level of expertise and with that curriculum, with that level of personality. So thank you very much, Livia, for everything. I hope to see you soon in Wrocław, which everybody knows that it's my favorite city in Poland, and I know many cities in Poland. So
I know.
I just want to say thank you once again, and Merry Christmas.
Thank you very, very much. Thank you for everything. It is my pleasure, my greatest pleasure to know you and to had this opportunity to spend time with your father, and many, many things which I know and which I still use in orthodontics I learned from your father. And I will still keep it in mind and in my heart. Merry Christmas, and I'm certain that he's watching us and taking care of all of us.
For sure. Thank you very much, Livia.
Thank you.